kind of, all of the above, but again, kind of the volumes are fairly low. So I think a lot of it now is just making sure that people, have the latest information, like about getting treated. I think that's still a big piece of people not knowing ahead of time if there's someone who should be treated or not. So we're definitely trying to make sure we get the word out about that. Also wanting to make sure that people know about the Novavax option. So for our remaining unvaccinated, which we know is not an insignificant number of people in Alameda County, we still do have some. So wanting to make sure they know about the Novavax vaccine technology. And then I think last but not least is just wanting people to get the information that we do have about what appears to be cumulative harms that can happen from repeat COVID infections, so that, people aren't saying, oh, well, I got it and I did fine, so I'm not that worried about it anymore. We want to make sure people understand that, if you had it once, we don't want you to get it twice. You had it twice, we don't want you to get it 3 times, because there is, now I think emerging evidence that there's increased, kind of a multiplier, if you will, that gets added when you get COVID repeat COVID infection. So I think that's another piece of information we're just trying to make sure people are aware of.
Cool. Noha, good to see you. Before you yield the floor, are you all seeing anything, any dynamics with regard to our unhoused, given all of the rain and all of the weather that we've seen? Are we seeing any distinctions in that part of our community?
As it relates to COVID, or just kind of in general?
Make COVID, flu, and in general.
So throughout the entire pandemic, actually, at least from our experience, those that are literally unhoused have had the lowest, COVID transmission rates out of all the groups that we're serving, at least at Roots. And that's something we were super worried about in the beginning. But obviously, we found out later that being outdoors is, relatively the safest place to be in terms of transmission, not in terms of everything else pretty much, but in terms of COVID transmission. Shelters is a different story that I know probably Donata and others could speak on more than me, but certainly as it relates to the storm, Healthcare for the Homeless has been awesome in getting additional beds freed up for folks so that we can get people, particularly those who are medically fragile, into housing. We've had a lot of really good movement, I think, in terms of getting more people who are vulnerable on the streets matched for housing. So that still feels like the big silver lining of the pandemic, is that there was a lot of kind of emergency shelter options that are helping to lead people into housing. So there was some additional resources that were made available to all of the street medicine teams in Alameda County because of the storm. So both in terms of, giving supplies out like heavier duty tents and things like that, but also making new beds available for those who are medically fragile. So that's something that folks moved on really quickly. And I think, has helped to mitigate some of it, but it's certainly I think about the folks, our unhoused brothers and sisters who are living on the street like every day and evening with this torrential weather that, we're all complaining about inside of our homes. It's really, it really is quite devastating just in general, but do definitely want to compliment Healthcare for the Homeless for making some resources available during this time.
Cool. Yeah, thank you for that. Anybody else from the clinician side? Dr. Carey, I see that you're on. Dr. Rhodes. Anybody else?
Hi, it's Dr. Carey. Sorry, I'm in transit taking my son to basketball practice, so I'm off video. I think, like Dr. Noha said, we're attempting to really continue that message that if you got COVID once, you got COVID once. It doesn't mean that you're safe from getting it again. We're seen lots of people having recurrent COVID and also having long COVID symptoms. So really just trying to educate people about that. Also, a lot more people are doing home testing versus going to laboratory to get testing for COVID. And so we've just continually tried to remind folks that there's extensions on the expiration of many of the COVID kits, and sending people to the FDA website so that they can check on their test kits to make sure that they're not expired, and to know how long they're extended and when their actual expiration date is. We've been doing a lot of education around that. In terms of pediatrics, we're still not seeing a great uptake on the pediatric vaccines or pediatric boosters. So really trying to talk to families and parents about getting their kids vaccinated. I mean, there's just, I didn't think that there would be as much hesitation around it because we're used to vaccinating our kids. But there is still some hesitation around, the mRNA vaccines for our children. So continually to talk to parents about the safety and efficacy of the vaccines and the importance of getting our kids vaccinated. So that's kind of where we are.
Cool. And how about you, Bruce? Anything that you're seeing from your end of the field?
Well, actually, the biggest things that I'm seeing are people who really don't want to get the boosters, adults, and feel that they can escape because they haven't become ill yet. Being out in the public, I got a number of questions, which I just got today when I went to the dentist. And it was basically the same things, which had to do with the safeties. And with the new variants, the boosters weren't made for those particular variants, they feel. And so why should you even think about those? The only other thing I can talk about as far as what I see around the cities in my areas is it's a no mask zone. I'm almost like the Lone Ranger in many places I go now. And so that particular part of safety is being ignored by just the majority of people. And I'm sure everybody else in their areas are seeing the same thing.
Okay, cool. Thank you for that. Anybody else from the clinician side, and as well, any other questions for either Nick, Donata, any of our community clinicians? Any other questions? Gary, you had a question or a comment? Hi, Gary.
How are you, Baba?
Happy New Year, man.
Likewise to you, man. Yeah, I'd like to make reference to the sadness of the fact that the testing is being decimated across the county. When we start relying more so on home testing, clearly individuals aren't reporting. And then the normalization of, as Dr. Bruce just mentioned, not masking, and the emphasis that was made with regards to our children under 6, under 5, et cetera. That's all based upon the messaging that we do to the parents who make the decisions about the vaccinations of their children. And so if we can't get the parents to be vaccinated, based on, again, this overemphasis on normalization, unmasking, the lessening of COVID, then the children are not going to be vaccinated. Those numbers are never going to increase in that regard. So first and foremost, I think, that there should be, by the county, a further emphasis and investment in increasing testing sites. Not decreasing, and the giving individuals the choice as to whether to home test as opposed to being tested otherwise, I think is to our demise. People have considerations of employment and other concerns. If they test positive, they don't want to report, so they can't go to work. They can't be, so we're in the same positions as we were previously, but now we're starting to decrease services. And I think that's based upon available revenues. And that is, I think, a discredit to, the outlook and of the future of COVID. And then again, I also want to make emphasis to the tridemic factor, right? A lot of the symptoms of COVID, flu, is it RVS, whatever, those symptoms are so similar in regards, then, are our numbers actually being reported, correctly? And are they, being misreported with regards to the accuracy of the influx of these various diseases and the variants? Just looking at it from the same perspective, but I see the resources available are being diminished in that regard, particularly from the county perspective. Just an observation.
Yeah, thank you for that. Hey, Gabriella.
Hi, everyone. Good to be here with you all. I want to echo some of the things that Gary is saying. I think that's similar to what we're seeing on the ground with our community. I think the difficulty sometimes with working with the recently arrived immigrant community that we primarily serve and the day laborers is that sometimes this information is still new to them, right? How do you even test? And a lot of times there's fear around doing it wrong or not knowing how to read the instructions, because we also deal with a lot of low literacy or no literacy communities. And so they prefer to go to a trusted site where there's clinicians that they can talk to and that clinicians can actually perform the test. And so I think this has been the difficulty during this last month and these last few days, trying to connect community members to these services, because they're also very limited hours. They're during times community members are focusing on work. And especially right now is the low season for jobs, especially for our day labor community and people that work in labor work. And so that means that every day that they're waiting out there on the street corners, a hope for a job, and they're not going to go get tested. And so I think we're still encountering the same things that we encountered at the beginning of the pandemic, similar to what Gary is saying. And now with just more limited services. And so even though we're providing, education on how to test, how to use these rapid tests, a lot of people are still, resistant to using them. And so I think this is something to look at. And I know that the focus moving forward really on these services to some extent is uninsured communities. So how do we make it accessible, even if it's still limited with the limited resources that the county has?
Thank you for that. Yeah. Any responses from anybody, Kimmy, Nick, anybody else before we hear from Neetu? All right. Neetu, you got it.
Thank you. Can we bring up the slides, please? So I'm going to talk a bit about our digital social media campaign that we are calling the Winter Wellness Campaign. Next slide, please. So these are targeted digital and social media ads. So what I usually like to do is tell folks, if you've ever gone to an online store, you look at some shoes and then you go to another website and there is an ad for those shoes. That's sort of what we're talking about. Those ads follow you around. And so these ads are currently running. They're in the field now, and they'll be in place through the end of February. The budget for this campaign is $25,000. And so what that does is allows us to target by age demographic, by language, and by zip code, and by income, to reach individuals and households who are in our priority communities. So using the digital and social media ads, we can really hone in on these communities and serve up ads so that we can hit our goal of having those ads seen 2.5 million times. And so we're using zip codes that we've used, throughout the pandemic when we're looking at testing and we're looking at vaccination. We're using those same zip codes. We're targeting that young adult to 65-year-old age demographic. And then again, looking at residents who are in those lower income brackets. The ads are being served up in English, Spanish, Chinese, and Tagalog. Next slide, please. So the way that the campaign was formed, we based the messaging a lot around what we've been talking about since the fall and going into the winter. What are those layers of protection, those measures we can all take to protect ourselves, protect our families and friends and communities from getting COVID and from spreading COVID. So the messages were really honed over the course of months, really, where we talked with staff within the COVID division, within HEP and HPCP, our health equity policy and planning and health promotion community and partnership colleagues, based around questions and concerns that they were hearing from community partners, bringing that feedback back and really talking through how do we address those concerns. And the thing that we were hearing quite often is reminding folks, really that we want folks to test, we want you to get vaccinated, we want you to wear a mask, gather outdoors. If you can't gather outdoors, we want you to improve your ventilation. Doing all of these things together improves your chances of not getting COVID. And then if you do get COVID, how do you ensure you don't spread it around? So that's how we really focused in on getting to the right message. And as those messages evolved, we really looked at how do we simplify it? How do we really get to the meat of the matter? And then once the messages, the ads themselves have gone into the field, we do what's called A/B testing. And so what that means is you see how those ads and those messages perform, and then you put dollars behind the ones that perform the best. And then in terms of the visuals, which we're going to bring up in a second, those are, again, were based on feedback as we developed the vaccination ad campaign that if you remember back, I believe it was last summer, we learned a lot when we were developing those ads. And so we used that feedback to inform the visuals that are going to be seen in this campaign. We shared those again with our colleagues to reflect back, what we're hearing in the field from our community partners. Next slide, please. So the font might be a little small on this slide, but we wanted to give you just a quick snapshot of the three areas of messaging. So again, really looking at what are those layers of protection? So what we're calling like a wellness checklist. So thinking about, again, all of those layers of protection. And then we wanted to highlight affordable care. So at least right now, vaccine and treatment are free. And so we wanted to highlight that. And then preventative care. So, don't wait to talk to a doctor, get connected with a healthcare provider now. And then, as we've been talking about COVID and folks being burnt out on just COVID, all the time, really broadening that message and making it more about getting routine screenings and getting, your regular recommended vaccines. But all of that really ties back to this idea of that overall wellness checklist. Next slide. So these are just some examples. There's a lot more of these, and obviously they're also translated into other languages. But we wanted to give you a snapshot of what some of these graphics look like. So the square graphics that you're seeing are the ones that you might see in social media. You might see them embedded on a web page, kind of in the center of your web page. The ones that are towards the bottom, the skinny horizontal ones, might be the ones that you would see at the top banner on a website. And those horizontal ones, or excuse me, the vertical ones, those would be examples that you might see on the side of a web page. And so all of these ads have, slightly different messages, but it's intended to be simple, get, a main point across. And then what you'll see is a call to action, get wellness tips, get the list, get our tips, and they all drive to one web page. Next slide, please. And so this is pretty small on your screen, but if you go to bewell.ac.gov.org, you'll see the live website. That's all of it also available in different languages. And that website lists out the various things that you can do, again, to protect yourself from COVID, but other respiratory viruses as well. There's detailed information about getting treatment. There's information about masking. And then what's also available on that website is this downloadable checklist available in English, Spanish, Chinese, and Tagalog. So folks have a physical takeaway checklist that they can download, share with others on how they can prevent spreading COVID. But you'll also see things like, pay attention to your mental health. We know washing your hands isn't necessarily the high priority around COVID, but it is for other illnesses. So we really cover a lot in that checklist. So I'm going to stop there for a second because I do want to go into some week 1 results, but I just wanted to quickly do a check if anybody had any questions about the visuals or the content itself.
Yes, I'm so glad you asked. So from the beginning, we've always talked about how since we have such a captured audience with regards to COVID messaging, with the push cards and the information that is being shared, other chronic diseases should be referenced. With Umoja Health, we do a lot of multiple messaging with regards to chronic conditions, as well as COVID testing, vaccination, et cetera. And I think it is, not wanting to overuse the disservice word, but when we're doing outreach and we're out there in the community talking to people, and if we have the opportunity to hand them multiple sets of information with regards to, health care and wellness, then we're actually serving our population that much more so, because some individuals may not be interested. And this is, I've experienced this in terms of knocking on doors and talking to people in general, in the community. Some people may not be interested in COVID, but you mentioned cancer, you mentioned diabetes, you mentioned any other, chronic condition, and they'll, my mother, myself, my son, or whoever has, this and or that. And so I think we should diversify our messaging, because, we're investing all of this money and all of this energy and emphasis in putting out these tools. Why not? And I know you did mention, that there were other aspects that you do, but I think it should be, it can be much better served, because if I walk down the block, I don't have to come back and, walk down that same block and message something else. One stop shop. One stop messaging. It really is that much more effective. And it also, last point, is such a great tool to further the conversation, right? Then you can open up other resources and other, offerings to them, and not just be solely, COVID related, because people have a tendency to be burnt out to that extent. But now you have an opportunity to engage them in other areas, and it is so effective. I'm complete.
Cool. Need to any response, and then we have Dr. Kim Rhodes.
Yeah, I would just very quickly say, I think, Gary's comments are well noted. I think that was one of the reasons why you'll notice, for example, a lot of the graphics don't say COVID specifically. They'll, mention maybe wearing a mask, but there's not like a specific reference to COVID. And that was one of the considerations. We know folks are burnt out on COVID. There is an emphasis on respiratory viruses, not just COVID, in the wellness checklist, in part because when this campaign was being developed, we were talking about RSV, we were talking about COVID, we were talking about flu. So we wanted to know that this is a winter wellness campaign. And so we really were honing in on the impacts of viruses that were circulating during the winter season and going into the holidays. But I think your point is well taken. We wanted to include references to flu, routine vaccinations, mental health. So you'll see some of that. But I think what I'm hearing, Gary, is that, as we look to do other campaigns that may not be tied to a particular season, there's opportunities to really lift up other ways of connecting people to their health and wellness. And I think one of the values of a digital and social media campaign is we actually don't have to physically go to folks. We can just serve it right to them where they are, which is mostly on their phones, which is what we're seeing through the results of our campaign. But I'll stop there because I know Dr. Rhodes has a question as well.
Sure.
Yeah, thanks for all that. And Gary, for always lifting up, not only promoting other things, but I think what's hidden in that is the suggestion that we think ahead. Because, when we come to the next health crisis, we'll be looking around and going, okay, what should we do? Instead of continuing to do this work as kind of the normal way that we message around whatever public health issues are out there. And in saying that, I want to put another plug in for how are you incorporating the youth voices? because they can help you across the board, teen pregnancy, STIs, like all kinds of stuff. So really, Gary, I think your comment really reflects on sustainability versus on campaigns, which are kind of, one-offs for whatever the season or the disease or whatever. But thinking more about the partnerships that have been built as a platform for sustainability of engaging community in their own public health. So that's separate, kind of a separate comment. What I was actually going to ask you is whether or not these are all evergreen because of this concept of cost and how cost is actually going to change around COVID, right? The vaccine's not going to be free forever. Paxlovid is not going to be free forever. So, just to think about that, because I think that day when that changes is coming soon. I think it's tied to the emergency declaration. It's going to go away soon. So
Yeah.
just kind of wondering about that, and not to give people the impression like through the pandemic, we've been saying we have the tools, we have the tools, we have the tools, which really is effectively not true because the tools are really hard to access. So I wouldn't want to give people the impression, well, it's like this is free and that's free, because it's not going to be free for long. And I'm just wondering how you think about that in terms of your message.
Yeah. So, and I appreciate that feedback. So, 100% agree that as we communicate throughout the year, and I think Kimmy put a great comment in the chat, there's multiple opportunities to connect with folks. This presentation is specifically focused on a limited by time campaign. So there's a beginning and an end with a fairly narrow focus, and it was really about honing in on the things that are happening during the winter season, the viruses that are circulating. And so the messaging is really tied to what's happening in the moment, because these ads will go away at the end of February. And so if during that time, there's a change in when the resources are available, if they come with a cost, if there's something that needs to be changed, the beauty of a digital and social media ad campaign is these graphics can be pulled and changed, in really 24 hours. So we wouldn't continue to have ads that are running that say something that's actually inaccurate. So that's one of the benefits of that digital and social campaign. We have control over that. So the website can be changed, the graphics can be changed, the translations can be changed. And the goal would be, as we're thinking about communicating forward, if there's a cost, I think from the public health perspective, we want to continue to connect people to low cost or free options if they are available. And there's a lot of nuance based on if folks are on Medi-Cal, if they have a private provider, if they're not insured at all. And so it's a complicated message, but we have been talking about it a lot. And I think it's going to require both, the sort of like mass communications that we do through social media and things like that. But I think it's going to be a lot of educating folks, because it's going to require thinking through where people are in terms of insurance, because that seems to be what's going to make the difference in terms of cost.
Yeah. Nitu, before you finish, go
Mm-hmm.
to the next part of your presentation, I want to ask Nick about the impact of the end of the public health emergency. And Nick, you may even want to say what you said in the chat out loud in terms of the impact on copays and that sort of thing if you're insured.
Sure. And what I put in the chat, I think I have this right. If somebody knows this to be wrong, please jump in and we'll take a deeper dive for the future. But I believe in California, the insurance regulators have made it so that COVID testing, vaccine, and treatment will be covered without copays for insured people in California. And we have a relatively high level of insured population here in Alameda County, fortunately. And I believe Medi-Cal is further expanding in 2024. Again, there may be others who have a better understanding of this than I. So it's not going to be, it could be worse. It'll probably be worse in other places, other parts of the country, maybe even other parts of the state. But also, I just want to acknowledge, we know being eligible for insurance doesn't fix access problems for a lot of people. And we know that people who had insurance or were eligible for insurance needed to use the services that we supported through COVID. So I don't want to don't want to oversell that. And then in terms of the public health emergency, so we have a local health emergency, which doesn't, so we have said publicly that when the state emergency declaration goes away at the end of February, we will also lift our local health emergency, local conditions permitting. That our local declaration actually doesn't, there's not a lot of funding programs or policies tied to that declaration. Outside of some may know that the Board of Supervisors linked the county eviction moratorium to that declaration, but that was a separate action by the board. It's not a normal part of a local health emergency declaration. But I think it, along with the state lifting its emergency, that'll contribute to people's perception that, first of all, that COVID is not an emergency, but also that maybe they shouldn't even be sort of seeking these services, even if there are still avenues for people to get support for things. So I recognize that it's going to be a confusing message for members of the public, but lifting the local health emergency doesn't make any services go away by itself. We know from the state various things are being dialed back over time. You heard a little bit about some of that with testing now. I think more will come over the course of the coming year. The federal government, a couple things. It's super complicated. I'm still trying to get a handle on it myself. We'll probably be able to share more at the next month's presentation. The federal public health emergency is probably the most important federal declaration. There's several other COVID-related declarations. We don't know when that's going away, but we expect to get 60-day notice from the current administration, and they haven't given that yet. And so we're expecting sometime in spring. The biggest thing, the most disruptive thing, or at least the thing that I was most concerned about with that going away, is Medi-Cal recertifications. That when the federal public health emergency went away, people who were on Medi-Cal and had their recertification processes suspended while the COVID pandemic, while the public health emergency was in place, would have to recertify, and that would result in people getting thrown off Medi-Cal just because they didn't have their paperwork in order, and or maybe because their eligibility changed. The federal government has I believe with the budget passed by the last Congress in the end of December, separated those and set a date. And Medi-Cal recertifications are going to resume in the end of on April 1st. My understanding is that for California, it's not a cliff, that it's going to be a rolling thing over time, but that's going to be a big disruption to people's healthcare in California. And that's a big thing we're concerned about. There's a lot of other stuff tied up in these federal declarations that we're still trying to get a handle on. There's going to be emergency drug authorizations that go away. Paxlovid will get a full FDA approval. It'll become a drug that's bought and sold by businesses to healthcare companies. But again, hopefully that state insurance rule that people can access it without copays will at least help. But again, our health system is already a mess, as you all know. It's going to be a mess for people, and we need to continue to support folks to access these things, even if they might be able to have coverage.
Yeah. Hey, Kimmy, you had a comment, and then Nitu, you had more slides, or were you done?
I have one more slide if people care to see just week 1 results, but that was really all I had.
Okay. Yeah. So Kimmy, and then we'll come back to Nitu, and then we'll go, and then Noha.
I'll hold my comment for my segment.
Okay. Noha, you had something?
Yeah, no, thanks, Nick, for that update about the public health emergency, because it does feel a bit confusing. And I think we're all worried about the recertification process and what that's going to look like. So at least we have a little more time maybe than we thought. But I guess my question, and maybe this is, sorry, Joe, if it's putting you on the spot, but I see Joe from the ACCMA is here. But I'm just curious, do we know if the primary care landscape is ready for this? I think, we're saying, okay, and primary care was essentially left out, with the exception of probably the clinics, was left out of the pandemic response. So a lot of primary care doctors' offices were not vaccinating, they were not testing. And to my understanding, there's still doctors' offices that aren't testing, for COVID, for example. let alone being ready to prescribe Paxlovid. And so I guess since so much of the response happened outside of the doctor's office, so to speak, do we know if we're ready? Like, are we surveying providers? Do we know if people, okay, so let's say all the stars align, they get recertified for their Medi-Cal, they have their access, to the provider, they show up. Does that doctor have the vaccines in their office? Does that doctor have the ability to test? Does that doctor have the ability to prescribe antivirals in a timely fashion? Like, what do we know about that, if anything?
We don't. I think that there's, it's going to be very variable, and it's probably going to be different at different times of year. I mean, there's a lot of potential challenges there, and I was just trying to. I mean, there will be barriers for sure.
Yeah, I was just gonna agree that yes, it is going to be very challenging, and I think I see Joe possibly chiming in. I want to put a pin in this for us, because I think that this would be a really good topic for our too, because there's a lot here and there's a lot that we have to kind of like know about and know who's going to fall through the cracks, where the cracks are, who's ready, who's not ready. Are there things that we can do to help providers get more ready for this? Because I think we have April kind of thing. And so when we think about agenda items for next month, I would like to see us spend some time on this, because there seems to be a lot of energy. And there's a lot that we just don't know and we're figuring out, and there's a lot to do, and there's a lot of concern by all of us.
Dr. Terry, I'm sorry, go ahead, Nick.
This is Joe Greaves from the
sorry.
ACCMA. I'm the one that Dr. Abalata was, I think, referencing. And for those who I don't know, the ACCMA is the professional organization of physicians. We have about 5,500 members. And I would just echo Dr. Moss's comments. I think there's a lot of variability. But Dr. Abalata, to your point, because solo small independent practices weren't necessarily factored into the initial planning, I think a lot concluded early on that they wouldn't need to be providing those services. They wouldn't need to be doing vaccinations. And so we've been working hard to try to get messaging out as more resources have come online and as things have become more, doable. But, when opinions are formed early on, it can be difficult to change them. So I think there's a lot of variability, and I'd say a lot of solo small independent practices are relying on community resources, commercial pharmacies and others to meet that need still. We are partnering with, and want to commend Public Health Department for making that connection, but we are partnering with CDPH to do some education on therapeutics specifically, so that physicians across the board know more about what's available for their patients, and hopefully see an increase in prescribing and utilization.
Cool. Thank you for that. And let's take Donna, Dr. Donna, and then we'll come back to Nitu, and then we'll move to the next part of our agenda.
No, I was just putting on my Alameda Alliance hat and saying that I'm happy to take that back to our team and our provider relations, and perhaps with our next meeting have some idea of provider capabilities to report back to this group.
Cool. Thank you for that. All right, Nitu, you got you can finish.
All right.
Some great questions.
Just one more slide, I promise. So very quickly, I wanted to just provide, this is just 1 week's worth of results. This is when it launched, which was mid-December through right after Christmas. So just for folks, just a little bit of grounding on the term impressions. That's eyeballs. That's how many times a person has seen it. The ad, it doesn't necessarily mean it's a unique person. But if you know anything about advertising, I know it works on me, you got to see something a few times before you take action. So impressions measures how many times an ad is seen, not how many individuals have seen the ad. So just in 1 week, we saw over 206,000. The ad was seen over 206,000 times, and it was clicked on over 1,000 times. So that means that people were directed to that website. The top locations by impressions: Oakland, Hayward, San Lorenzo, San Leandro. Top locations by clicks: Oakland, Hayward, San Leandro. So we know our geo-targeting is working. What we are learning is folks are mostly clicking on ads through their mobile phones. And then in terms of who's looking at our ads, we're seeing the most impressions among people who are 25 to 44. And the ads that are being served up most, again, because they're being seen the most often, are English and Spanish. So we are obviously running Chinese and Tagalog ads, but based on the performance, English and Spanish are the ones that are being seen the most often. So I will stop there. If there's any questions about these, the campaign, I'm happy to take them in the chat. But I appreciate the time and opportunity to inform you all about this campaign.
Cool. Thank you, Nitu. Good job. Thank you so much. All right. And the next item on the agenda is we're going to hear about the CAG going forward. And to introduce that topic is Kimmy. Hey, Kimmy.
Hi, everyone. And so, you know, last month, we spent a little bit of time, not very much, just introducing to you all the notion of us talking through how we want to maintain our relationship with each other. We have really appreciated the relationship that we have established with all of you. Some of you are new friends and partners. But most of you are partners that we knew already, but we've had the opportunity to work more closely together over these last few years. And we would really like to stay in relationship with you. And so want to really have you join with us to think about how do we want to be in relationship with each other. Having this monthly meeting is one way of connecting and staying connected. But we want to hear from you and kind of know, you know, so it's more than, and know what your thoughts are. So it's more than how do we want this meeting to go? It's actually, we want to talk about and have you think about, do you want this meeting to continue? Are there other ways you want to stay connected with us? How do we leverage and support and maintain the momentum that we have built and the strength of the partnership and the relationship that we have built over time, whether or not we have a monthly meeting per se. And so we are going to this evening have a quick survey to ask you about specifically, you know, this meeting, you know, because if we all choose that we want to continue to meet, even if we broaden the topic on a monthly or every other month or some period, you know, some schedule, how would you like the meeting to be structured? What are the more important parts of the meeting? And so Lauren is going to be running that survey. Then we'll have breakout groups where we will talk about and get your ideas and thoughts about how do we want to stay in relationship with each other? How do we leverage the partnership and leverage the strength of us all working together and planning together and thinking together and being thought partners to do a lot of really good work out there together. And as you all can see, as we can all see, there are so many other areas of work that we need to work together around. COVID is a small, it was large, but it is only one piece of the healthcare territory and of the public health territory that we really need and rely on your partnership and support around to keep our community healthy. And so with that, I would like to turn it over to my colleague, Lauren Barranco, who will walk us through a Zoom survey and then will lead us and instruct us into the breakout sessions that will happen after.
Thank you, Kimmy. Thought we could just take a quick 2 minutes. I'm going to put up a poll. Unfortunately, right now it's only in English. We'll send it out to attendees in Spanish after the meeting to capture, but we're asking you just to quickly rank the 3 most important or valuable parts of a CAG meeting. So I'll show you what it looks like and I'll launch it right now. If you can click on the poll button if you need to on your screen. It's anonymous, and we're just asking what you think are the most valuable parts of being here. Are they our data updates? Are they our partner updates, et cetera? And this will just help us get an idea of what you're getting out of here. So I'll give maybe 2 minutes for this, and then we'll give instructions on breakout groups. Thank you.
And you said just choose top 3, correct?
Yes, please. I mean, I don't have a mechanism to see if you cheated specifically, Aaron Ortiz. No, just kidding. I don't have a mechanism to see if you've chosen more, but 3 will help us narrow it down a little bit. Please. Thank you for asking a clarifying question.
Will do.
I'll just give it another 15 seconds or so. Sí, Gabriela. I made it anonymous, so I don't know. Okay, so we've got about 20 of the 34 folks, 21, 22 people participated. I'm going to end the poll and share the results briefly. Looking like partner updates and COVID division strategy updates are some of the more valuable parts to being here, closely followed by COVID data and some of the other components. So thank you. This really helps us get an idea of how we can structure these meetings going forward and what is of value to you all. And I'll send this out with the notes as well. With that, wanted to transition us into breakout groups. We thought we could get into small groups and have a little discussion about following up on what Kimmy was saying and where this relationship can go that's been developed and really honed in this space. So we'll have, I'm going to put our county staff in one breakout room, or the bulk of our county staff in one breakout room because to talk amongst ourselves. And then we have 2 more breakout rooms, one being broken out and then in this main room. You have the option to move rooms, especially for those who want to participate in Spanish or who are listening along with our ASL interpreters. Those people need to be in this main room. So you can come into this room at any time. So I'll give us about 17 minutes to break out, and then we can call back or maybe 15 minutes and have some really quick share outs. Each room will have a facilitator and a note taker, and we're going to ask the note takers to do a brief report out and ask the group if there's anything that was missed. Any questions before I break people out into groups?
Yeah, how's the baby?
Baby's good. I'll try to conjure up a picture of him and drop it in the slide deck.
Pictures.
All right, folks, I'm going to get us started and we'll bring us back in a little before 7 to be able to report out. Thank you all. Nestor and Angela, I believe you are the facilitators in this room. So I'll stop sharing.
Right.
Unless you want me to keep sharing.
Yeah, why don't we keep it up for now just so we see the questions.
Okay.
I let's see who's in the room with me. I see Dr. Bruce. I see Pastor Arlene. So, and some other folks. Hi, everyone. Why don't we start with the first question, and then Angela will be taking notes for us. And so just as a reminder, especially for our interpretation, to speak slowly. What do you want to see us accomplish moving forward? Who'd like to kick us off? Joan, I see your hand.
Yes, hi. I'm sorry I can't see anybody because of the screen being up, but I've been coming this entire time as a representative of all of the Alameda County school nurses and mostly bringing back the information, which has been incredibly helpful. And the networking, both for the school nurses and here, has been so important over the past couple of years. What I would love to see is another way to help integrate the school nurses with the community organizations so that the organizations that are working with the children know what's happening in the schools, and there's better communication that goes on, because this is actually the pediatric public health population that our school nurses are taking care of.
Thanks, Joan. That sounds like a great recommendation, but that's just me. Let's see, who else would like to contribute? Gabriela.
Yes, I think for me as well, I've been coming to these meetings from the beginning, and I think it has been very helpful to highlight, especially some of the most highly vulnerable populations. I think at times we know about these populations at the systemic level, but I think it gave us an opportunity to actually put some solutions to it. So street level has been working with the day labor and recently arrived immigrant community for the last 21 years. And I think this is the first time I have been able to witness some real things to put into play for this community. And so for me, I think it's important that more people understand the challenges and barriers that this community faces beyond just our organization, so we can work as a team, work as a group to be able to provide these resources and services that this community needs. And really for us, it's important to see the whole person care model. So while COVID was the tip of the iceberg, we know that there's a lot of issues to access to healthcare and other social services and other resources. And so I think moving forward in this group, I would like to see that continuation of how do we also tackle some of these other social determinants of health together.
Thank you, Gabby. Let's go to Pastor Arlene now. Pastor Arlene, was that a mistake? You didn't have your hand up?
Sorry. Yes. No. Pardon. I had my hand up and then I dutifully put my hand down and I forgot to unmute myself. So I completely agree with Gabriela, what she said, and I think quite honestly, for somebody who feels like she's running a MASH unit for COVID this whole time, it's been a source of hope in a very discouraging time, that knowing that we could, as hard as it was, that we could get the most accurate of information that was available to understand what we were dealing with, and to feel like people of influence cared about our communities and would take seriously our input. I've been on a lot of committees where people say they want your input, but it doesn't really feel that way. So it's nice to actually have experiences where there's change. You see change happening, modifications happening because of the effort you've made to share and so forth. I also really appreciate, public health has to deal with so many people and so many hard things, and so naturally a lot of information gets aggregated and so forth, but I continue to believe that oftentimes the genius can be found really in the granular and the anecdotal, in the particularities and so forth. So I've really appreciated that. and I also I have mad respect for Dr. Kim and her just telling it like it is. She's been great. Yeah. So I feel like I've made a lot of friends, and I feel like I actually know who to call now and who to talk to about things. And I don't know, I hope people still call me back if we don't meet all the time. Yeah. Thank you.
Thanks, Pastor Arlene. Dr. Bruce, what would you like to see us accomplish moving forward?
So I have a different viewpoint, I believe, from where a lot of things are here, because I see the word us in both number 1 and number 2. I don't see a lot of us coming back from what the community feels are necessary as far as moving forward. And just even on the list of things going out as to what you have to do that was presented earlier, it was a good list. There were 13 things that you had to do to be healthy, but how many people are going to get past the first 3? And I think there's a lot of us that's important to actually have, not necessarily saying anything negative about community leaders who are, part of the group, but sessions with actual people within the community, and then having the community leaders come back and say, this is something that would be very, very helpful. And I haven't seen that a lot through this. There were a couple of things where we got teams together, which was part of my suggestion to help that go. But I'm not seeing how the community is feeling about what's happening in the same sense that they're really part of how you're making all your decisions. I also understand that you have certain things that you can do and certain things you can't do because you're part of the Alameda County sections here, but I think that more community involvement in making programs work would be something that should be accomplished, as well as continuing to talk together, because I've learned quite a few things with all of the discussions we've had and brought some of them back out. But I do think there's more to this program, having been on a lot of community information sites and adding and then finding my thoughts and decisions as to how to go further forward actually changed because of true community input. So I know that sounds a little bit different than what you wanted, but I think that that's an important part that's been lost. And I think that's something that should be accomplished moving forward in the future.
Thanks, Dr. Bruce, and all just to encourage all viewpoints, and that all viewpoints are welcome, and I think you have folks that agree. So not an alternative take, but a valid take, or alternative takes are valid as well. Any other thoughts on what we would like to see the us, as Dr. Bruce highlighted, accomplish moving forward? Yes, Gabriela.
Just one quick point to add to what Dr. Bruce was saying. I think if we continue groups like this, and I know this has been our experience at other tables similar to with public health, that it starts off well, right, where there's a lot of ask from this side of the community or community organizations. There's a lot of feedback that is given, but I think sometimes what tends to happen is an attention is created, right, with the systems that we want to see changed, and then the structure of the meetings start to change, right, where then there's less room for us to give that feedback, to have those honest conversations and dialogue, and we start to kind of get shut out, for lack of better words. So I think I kind of echo what Dr. Bruce is saying, and I think this tends to happen a lot where we start on this path together of the us, and then it starts to feel like more we're being talked at. And I'm saying this from the experience of the community resilience meetings. It started off in that way, and now it's kind of shifting back to just kind of like being talked at us and not really with us, right? So I think just being mindful of that if we're going to continue these conversations. And I have appreciated having you, Nestor, and Greg, facilitating. So I think that's helpful when facilitators know how to navigate those tensions.
Thanks, Gabriela. Dr. Carey.
So I was thinking, as everyone was speaking, how to sort of craft this without being too long-winded. I feel like all of us who have been on these calls since the very beginning, that, we were sort of thrown into this sink or swim, live or die situation. And that in the process of really trying to make sure we kept our communities alive, I think we did lose the us in the community. In particular, one, demographic that has always stood out as really needing the most emphasis in terms of age has been the 18 to 25-year-old group. But I haven't seen us really involve them in our conversations. Nor have we really done the, adolescents. And I feel like as we're moving forward, that we need to involve the organizations and the communities that we have the most difficult time reaching. And we've seen that throughout the pandemic in their positivity rate, in their low vaccination rate, and their high COVID positivity rate. And so I think when we're thinking about the us, we should also be very clear about communities that are missing and what we can do to outreach to those communities to really bring them into the conversation so that we can really make the true impact that we're attempting to make. So I think I'll end there.
Thanks, Dr. Carey. I think that's actually a good transition place for the next question around what models do we want to see for us going forward, and then what types of relationships. I heard a little bit from Gabriela that there's this sort of process in which it starts off maybe really hot, but when it cools down, it begins to or like in this process of it maybe being too hot, it begins to narrow the sort of a feedback piece or the back and forth piece with community members or community groups and the county maybe. So what sort of models do we envision in these last maybe 3 minutes that we have that might help us accomplish some of the things we've mentioned moving forward? Dr. Bruce?
You already know that getting together groups is hard to do sometimes, but very easy to do if you go out in the community and say, who wants to help? And you did have, like I said before, smaller groups of teens available at one time. And I think that those would be very important. And asking community members, do they want to be part of this in their particular sections where they live, or in a place where they don't feel that they're going to be overwhelmed by the people who are just part of the county and won't really listen to what their real feelings are. That's it.
Okay, so maybe smaller, more geographically organized groups. Gabriela?
Mm-hmm.
Yeah, speaking to the part about community members, I did try to have a community member participate at this table at the beginning. But what I heard from him, and was really some true feedback of like, okay, what is the point of being here? What is our community really getting out of this, right? So if community members don't see, the full picture and don't see things that are being implemented in the community, they will fall off. And also we have to recognize a lot of us here are getting paid to be here, right, to some extent. So that's another factor of thinking about how do community members participate in these spaces.
It's a how can we help you to help us help you, and not we want to help you this way.
Thanks. I think the rest of the group is back. And so am I facilitating this part, Lauren, or someone else?
No, you've got about 12 seconds, and I think folks will come back in. Oh, you may facilitate it if you'd like. It's asking each note taker just to report out really briefly.
Excellent. Okay. Because I see some folks have joined. And so let me know when we're back at full capacity.
I think we're back.
Excellent. Welcome back, everyone. It's nice to see everyone. I hope you all had great conversations. I know our group had a really good and productive conversation about how we want to move forward and what we want to accomplish and what sort of models we want to kind of see moving forward. So our note takers are going to do a quick lightning round of sharing of what were some of the highlights of the conversation. And we will start with, why don't I start with my group, which I think Angela was taking notes for that.
Thank you, Nestor. Hi, everyone. My name is Angela. I'll try to be brief. For the first question, what do you want to see us accomplish moving forward? We had someone who's a representative of Alameda County school nurses, and they mentioned they would love to see an integration with the school nurses and the community orgs, just to know, so they know what's happening in the schools and they have better communication between both. Others have said it'd be helpful to highlight the most vulnerable populations, understanding the challenges and barriers that their community faces beyond what that specific program is hearing from their communities. And then there's someone said there was a source of hope in a discouraging time with these meetings. What they appreciate about these meetings is that they're able to get the most accurate information when it is available, and that through this meeting they have seen that people of influence have actually cared about their communities and are seriously taking their input. Someone mentioned they had a different viewpoint. In the questions they mentioned how it says us, but they don't see a lot of us within these meetings, such as like how the community actually feels, and how there's been a shift with how the meetings first began, in terms of it seemed like there was more input from the community orgs, and now it feels like they're being talked at instead of being also an active participant in the meetings. And a big aspect was they don't feel like the actual voices of the community members are being heard or are available at this table. Yeah, so a lot of just like who is the us in these meetings, right? Is it the community members? Are their voices being heard? And that doesn't seem to be true. Another thing was the age group between 18 and 25-year-olds seems to have been missed in these conversations. Same with adolescents. So how do you reach them, especially communities who have a high COVID positivity rate and low vax rate, for example? And then for the second question, what models do you see for us working together moving forward? What type of relationship do you want to see? So again, just getting groups together can be difficult sometimes. It seems to be easier when you actually have individuals go into the communities and talk to folks, and asking if they want to be part of these types of discussions, but also understanding that it can be overwhelming for them, especially if they feel that the county won't listen, and having kind of these smaller geographically focused groups. Another feedback was community members not seeing things being implemented. And so their viewpoint of like, what is the point to even be here? And lastly, someone said kind of like this notion of help us help you. So tell us, how do we help you as a community? And is there anything from Nestor's group that would like to say if I missed anything?
I think you did a great job, Angela, of covering the points. Thank you. We will now, I think the other group was it Donata's group? Is that the other group? Yeah.
Yeah, Drew took notes. So Drew, I'm going to turn
Drew.
it over to you.
Hi, thank you. So I'll jump right in. What under the category of what to see accomplished moving forward, the first did, and then there was lots of agreement, and it was around diversifying our messaging toward chronic conditions, and that the diversity of our community dictates that strategy, and COVID has given us an opportunity to really connect with our communities in new ways. And we would like to see we can coordinate these groups together to target specific communities and health challenges more as a coalition. An example was given as childhood obesity, and how can we pool all of our talent and resources together to make meaningful change? Others agreed and expanded upon these thoughts. The great opportunity we've had to build a diverse group of organizations to deal with both crises that arise and normal long-term struggles. Some additional thoughts were that one positive outcome of the COVID experience has been more of an opportunity for the healthcare and social services network at large to collaborate with the public health organizations. And at times it can be challenging to understand which groups or orgs are focusing more on social services and which are focusing more on healthcare services. So a slight feedback there that maybe getting to know which orgs are targeting which topics best. Let's not lose all this infrastructure that has been built, and let's apply it to other things. We are finding out about the commercialization of COVID response issues or topics. We need to make sure that it's as smooth as possible as it moves to commercialization, and not overestimate that the system is ready for these changes. And in communities of color, we know that the levels of service are diminished, and we don't even sometimes know to what degree, because we're not always sure that the data is capturing all of those inequities, but we need to bring those inequities to the forefront. Under the category of what models do you see moving forward, and what relationship do you want to see? Issue or concern was raised around enrollment and redetermination for Medi-Cal. It needs to be better streamlined and with better safety nets to prevent people from falling off. And the big issue with children not being up to date with their vaccines, even just the routine vaccines. And there's lots of disinformation that's affecting these outcomes. We need to be concerned about mental health, the mental health care system, and the mental health of our children. And this person's group has utilized, this was feedback for CAG, their group has utilized a living document that has allowed them to add and expand on new ideas on a rolling basis that everyone has access to, and it allows any and all to see these ideas, input, concerns, and thoughts together. And then lastly, infrastructure is key. With COVID, people really just had to hit the ground running, and people were moved around to respond to COVID from other areas of our public health system. Funding for a response like that is not something that exists always. And we really need to, there's no place for a coalition work like this to exist within the organization chart or long-term structure of the public health system, other than maybe a meeting or a living document. But what is the structure of the public health department that could allow a place for this coalition to land, to meet current challenges and future challenges? Also would like to see the public hospital system, Alameda Alliance and FQHCs. It would be great to see these important partners engaged in this coalition. Thank you.
Thank you, Drew.
And let me know if I missed anything.
No, it's great, Drew. Thanks.
All right, so I think we're at 7 o'clock, and I think the tummies are rumbling if folks haven't had dinner yet, and so I'm just gonna close this out here. I want to thank our note takers who did a great job of taking notes and reporting out, and thanking our interpreters as always, and thank you all for being here tonight. We're going to be meeting again in February, and of course the county will take back all of this wonderful information, the polls, the notes that we took, and have Gary, you read my mind. I don't know what gave it away. They're going to take back all this great and wonderful information, and we'll hopefully think it over a little bit and make some adjustments, and of course come back to all of you for feedback on those adjustments. So I hope everyone has a wonderful evening. Stay warm, stay dry, and yeah, Mike Rubio presente. Right. Take care, everyone.